I and I want to make sure that I'm always in touch with you guys. The work that you guys do for the community and for people around is important and is tangible, and it is something that other groups should look at, and you guys should be proud of what you have done. We have done Men Make It Happen before, and because of the COVID, we couldn't. And I think next time it would be very important because it will be 3 years, and in those 3 years, many things can happen, and many things can happen for other people who do not get looked at. So, and like, I think it's an opportunity to talk. And the topic for today actually is something that is really cool. It's new, and we have done a lot of progress there. So I'm gonna start doing my, if I can get my share screen. I think Ed, you're not allowing me to share my screen because it says the host disabled participant screen sharing. But my screen sharing, I think it would not. That's your screen. Okay, then. Oh, here we go. Okay. All right. So what we're going to be talking about is fusion biopsy. It is not a simple topic, and it's really top technology. So TRUS, what does TRUS stand for? It's T for trans, R is for rectal, ultrasound, US is for ultrasound. So we call it, usually we say, I'll send you for a TRUS biopsy. This means for the patient who's coming from me for prostate, like to check for prostate cancer, this is how we're gonna be checking. We're gonna do the regular transrectal ultrasound guide biopsy. But the new thing in here is the word fusion. And fusion here is basically, as we know, the meaning, it's we're putting two things together, or fusing two things together. So what does it mean exactly? So as you know, the transrectal ultrasound is basically the gold standard approach that's done everywhere. And the patient who comes for this, we tell them we're gonna go into the prostate, into the rectum, we're gonna put the ultrasound into the rectum, the probe, and then we're gonna biopsy certain areas. When I'm saying certain areas, I'm just going into a location. I'm not looking into a lesion. I'm not finding any area that is, I cannot tell if there's any area that is suspicious or not. Now, there are some ultrasounds that can, with certain techniques that can show maybe some surrogates, maybe, or some indications, maybe an area with high blood flow that might indicate cancer or not, but it is still not accurate. So the regular ultrasound biopsy that most people get is just, we go in a certain location, say, okay, I want to hit this area and that area, and we just biopsy that. And because of our inability to visualize and target the lesions, we can have errors. We can miss. We might miss cancer that is serious, and this happens. So basically, if you look at the top here, this is an ultrasound probe. We put this into the rectum. You can see on top this is the guide that we can put our needle through it. You can see here on the bottom, the ultrasound probe gets into the rectum. This is the prostate. You can see the rectum is here. Do you guys see my marker? Perfect. So you can see the prostate is there, and the rectum is there, the bladder, and this is the urethra here. This line here is the urethra. So the needle goes directly through. And on here, you can see this is the image that I would see. I just know these are the limits of the prostate. I don't know anything else. I cannot tell if there is a cancer here or there. I'm just aiming towards an area, and I'm hoping that this sampling is going to show me the cancer. So if you look at the prostate has different areas. Now, again, you can see here, this is the rectum, the peripheral zone. There is something called the central zone and the transitional zone. Okay, most of the cancers are in the peripheral zone. Sometimes we do what we call a TERT, and we find some cancer in the transitional zone, but not as much. It's less than 5% of the cases. Sometimes you find some cancers in this area, which is anterior zone, which is an area on top at the anterior part of the prostate. So if we let me go to the next one. So in a standard biopsy, we go from the rectum. This is the prostate, and we divide it into a template like this, like a grid. And we just say, I'm gonna pass a needle here, I'm gonna pass a needle there, and so on and so forth. Which, in a way, you should be able to get the cancer. But what if I go with my needle here and the cancer is there? I missed it. It's negative. So we take usually the minimum is 10. I take 12, if not more, depending on what I'm seeing. But this is from the standard transrectal biopsy. It's very easy, cost effective, and please, when we talk about cost effective, you have to put a lot of lines under that. This is a very challenging situation for the governments, and this is where we all have to understand the reality of our system. It's an office-based or even outpatient-based, but the downside of it, it's false negative, meaning that I might get a negative up to 30 or even 40%. Meaning I go in, take a biopsy, comes back negative. I tell the patient, oh, well, you're negative, there's no cancer, but there is actually cancer. So maybe I'd say 10 years ago or so, we started having a new idea about doing MRIs for the prostate. And looking at it, like basically they said, well, the current way we do the biopsies for the prostate, we can miss stuff. Sometimes we imagine if I get 2 or 3 biopsies out of the 12 that came back positive for some cancer, but it is the only area that has the cancer, and the rest of the prostate is all good. But then I'm thinking, well, this patient is having cancer, then I might have to treat, so overdiagnosis and overtreatment, which what happened big time in the US, or underdiagnosis or missing the diagnosis, which can happen. And I have many patients that I have seen. I have patients who've had 4 biopsies in the past and it has been missed. Is it because the person who's doing the biopsy is not a good clinician or no? It is the reality and the limitation of the test. So they did an MRI. They said, okay, let's look at the MRI of the prostate, and they wanted to see if it's going to be helpful. And they found that basically, I'm going to go back here, that when we do MRIs of the prostate, the MRI has the capacity to detect prostate cancer, but only or mainly the aggressive types. So if we talk about prostate cancer, we know we have from Gleason 6 up to Gleason 10. Usually MRI would be able to detect Gleason 7 and above. So people would say, if we do an MRI, what does it mean if I have a lesion? If we have a lesion on the MRI, they give it a number between 1 and 5 called PIRAD. And this does not mean, it's not like Gleason score. This is 1, 2, 3, 4, 5. It is a number that we give to say about every lesion, how likely it is it to be a prostate cancer lesion. But it doesn't mean how likely is it to be aggressive or not aggressive. Most likely, if any lesion is detected by MRI, it is one of those aggressive lesions. So if somebody has non-aggressive prostate cancer and they get an MRI, the MRI is not a good test for that. And this is very important to understand. MRI does not have the capacity. It has some for sure, but not as sensitive as we would expect it to be or want it to be for the less aggressive prostate cancer. So somebody would come and say, you know what, who cares? I only want to detect the aggressive cancer. I do not really care about the non-aggressive cancer, because non-aggressive prostate cancer, it is not going to affect the patient. This is true if you are an older gentleman, or if you have life expectancy less than 10 years. But if you have life expectancy more than 10 years, I want to know about the prostate cancer that is less aggressive, because you know what? It has the chance of progressing. So basically, this is an MRI. If anybody had an MRI before, very claustrophobic. Patient goes in. This is the image that we get. And to tell you the truth, it is one of the hardest images to see. But after a while, you get used to it. So you can see on the left here, the prostate looks like bumpy or has like all these small circles inside, but nothing is dark. You look here on the right side, this area, you see this is the whole prostate here. And you see this is the whole prostate there. And there's this area in the prostate. If you look at the normal here, it should be like that. And this area is dark. And this is the peripheral zone. So this area is abnormal. All right. And we know now that this is an abnormal area. So what's good about the MRI? It's very sensitive. When we say higher sensitivity, I want to be careful people understand. When you talk to others, it is higher sensitivity for the aggressive prostate cancer. It shows me amazing anatomy, and we use the MRI now. Dr. Koto, for example, he tries as much as he can to get MRIs for all our patients going for prostate surgery, to make sure that the cancer has not gone outside the prostate. It's very sensitive in this, and it's very good. We're doing some studies about that. The cons, well, it's expensive. I sit on the board of the foundation. The hospital, good news, but I'm not sure how much I can develop. But the hospital is buying a new $3 million MRI machine called the 3T MRI, top technology. It's amazing, but again, $3 million. That's a lot of money. And one of the downsides of the MRI is that it is a very long test. So we cannot do manipulations when we're doing the test. It's a run that has to go. So I cannot do the test or the biopsy while I'm doing the MRI. While, for example, if a patient is having a CAT scan, while the patient is having the CT scan, I can do the biopsy or whatever I want to do, or the intervention. In MRIs, we cannot do that. So what about the fusion? This is the topic. To make it simple, this is a banana and this is an airplane. You put them together. If I put these two images together, I get a banana plane. And this is exactly what we're going to talk about. So in the past, after the MRI was done, and if we go back to this image, and I did this in maybe 3 years ago and 2 years ago, I get this image and I say, okay, I know that this is a lesion in this area. I tell the patient, I'm gonna go and I'm gonna try to target this area. So you go with the ultrasound, as we has shown before, and I don't see this lesion on the ultrasound. It doesn't show up like that on the ultrasound. And I just keep firing the biopsy needle there to try to catch many areas, many biopsies and cores from there, hoping that I'm gonna catch it. So this is called cognitive fusion. Basically, I'm thinking, oh yeah, I know what it is. I'm gonna do it. It's operator dependent, and I can tell you what, it is heavily operator dependent. It is not costly because it is the same cost. You don't need a lot of technology with that. It's just the same ultrasound. But the reality is, what we think is, for example, if I want to go here and this image here, if what I think is this on ultrasound, it is not the same. It was very surprising how we think we're in that area, but we are not in that area. So what about the fusion based on the software? Well, this is the new technology where we get the ultrasound, software-based fusion, where we get an ultrasound machine that has the capacity to check on the ultrasound, and in the same time, you get the MRI that we have done before. So I have done it a week or two or a month before, and I put the two images together. So when I put the two images together, it minimizes the error and it maximizes the accuracy. So what happens exactly, like what I even realize is that the areas where our patients are having the lesions, they are in a very, many of those lesions which are missed initially are in a very awkward position or places in the prostate. So if I'm going to go back in the presentation, I'm going to show you this part in here. If I'm going to go with my ultrasound in the rectum and my needle goes like this and like that, and it keeps going all the way around in here, I miss a lot in here. It's very hard to go in an angle that's going to be extremely uncomfortable for the patient and go and hit across. And sometimes you hit across and you go through the urethra. The patient starts to bleed even more. So this area, where's my thing here? Huh? Oh, yeah. So this area where we find a lot of cancers are getting missed because we never really go there. It's a very hard area to reach. So with the MRI, now we are able to do that because we basically put the images together and we know where to go, and it doesn't matter. I would move my ultrasound probe and my needle guide to basically have a bullseye on that area, which is marked on the ultrasound. So who are the candidates who can get this fusion? Now, when I'm talking right now, there is a new ruling that came out from Cancer Care Ontario, but the ruling before that was patients with continued suspicion. Like if I'm thinking that my patient is still having prostate cancer despite negative thrust biopsy, I can do it. Is a good chance. It is a good thing to do for this patient. And the other option is basically for this kind of patient is to do what we call saturation biopsy, which is doing more than 20 biopsies, and it has a lot of morbidity, bleeding, infection, and many people do this under general anesthesia. Now, it's also patients who are going for active surveillance for the prostate cancer. Basically, I would say a fusion would help. It's a confirmatory. It improves if, let's say, the patient is on active surveillance and I have to check again in 6 months to a year to check again their prostate. I think those patients are also a good candidate. They're good candidates for that. Although a recent research study has shown that there is no real difference between doing an MRI biopsy and biopsy versus just biopsy. Now, if you look at this here, this is very, very important. Fusion biopsy resulted in reclassification around 36%. So out of 10 patients or 100 patients, 36 of them would have a different staging or different, a different situation for the prostate cancer. And for me, that is quite significant. In medicine, we always think of less than 5% is not significant, but 36%, that is a lot of patients. That's a lot of over-treatment, a lot of under-treatment, whatever it is, it's a lot. So if you look at this, if you have a patient, if someone is on active surveillance for the prostate cancer, after doing the fusion biopsy again, they were reclassified, which means that they had to get treatment. So if this patient did not get the fusion biopsy, they would have been having the wrong choice of treatment. Now, this takes the idea of the number needed for biopsy. Tells me my internet. Can you guys hear me properly?
Okay. Sometimes there's an echo.
Okay, because it tells me my internet is unstable. That's why I'm just Not sure what's happening. Okay. The number needed to biopsy for progression, meaning if I'm having patients that are going to that I'm looking at them for active surveillance. They have prostate cancer, but they don't have an an aggressive prostate cancer. The original number with a regular biopsy, with a regular trust biopsy, I have to biopsy 8.7, let's say 9 patients in order to tell one of them that maybe your cancer has progressed or your cancer has to have more aggressive treatment. While if I'm doing fusion biopsy, it is 3 patients. So I have to biopsy 3 patients to tell one of them that 1 out of 3 will be told that their cancer has progressed. So this means less number of biopsies, less morbidity, and better classification for our patients. Now, this is the best one. This is how it's called. This is the Cadillac of all of them. This is what we call the transperineal. So remember, when I was talking before, I was saying fusion biopsy, it was transrectal. We would still go and do the needle biopsy from the rectum. The transperineal is completely different. The ultrasound goes into the rectum, and then we have this grid, which looks like what they call it, the game that I used to play when I was young, Battleship. So on the same idea, we put the 2 images together between the ultrasound and the MRI, and the software tells me where to go. It tells me go to M9, and I basically hit it through M9, bam, goes through like this into the prostate and tells me where to stop exactly, and I get out. Now, since this is going from the skin, you just have to clean the skin and you don't risk the infection. So it is less infections and less intensive care, less bleeding, etc. Now, they say some people, like this is a study that says 2 to 4% they get infections. A study that came out from North York and Toronto, and they were the leaders actually in Canada. And this is the group that I want to go and get to do this, to learn this from them. They have 0 infections after 300 patients. We have to remember, patients who are going for transrectal ultrasound, 25% of them, they have resistance to the most common antibiotic, which is naproxen or ciprofloxacin. So this is why going with the transperineal approach, it is definitely a safer option. Now, some people, they do this other option, which is called freehand, where I don't have to have this grid and I can go with the needle. Just I go and make an opening in like a small opening like this, and I go with the needle and I go through I move the needle on the inside. This technique is not very popular, but some people do it. It is easier in terms of in one sense that you don't have to use the grid, and it can be used under local, but still you can even use the other one that I showed before with local anesthesia. Now they always say that the transperineal biopsy under local anesthesia is how to tolerate it is very similar to the transrectal. So right now we give local anesthesia. For some patients it hurts, for some patients it doesn't. It depends on the patient, but the tolerability is the same. So basically, we have in Thunder Bay right now, we have the MRI. We are getting the new MRI. We're actually lucky to get a very nice ultrasound machine that has the fusion capacity. We have even the transperineal probe. The only catch that is happening is that I just need to have some time to go down to North York to learn the transperineal technique. This is something that I have not done before myself, so I cannot practice on my patients. I need to practice, like to have somebody to teach me how to do it, and hopefully this will be the future. Now, the limitations of what we're doing is that, number one, are we doing MRIs on all of our patients. And many patients would ask me, well, should I get MRI or not? In the past, I used to tell them, well, if you have the dollar, you can go down. I have some patients who went down to Duluth to get the MRIs. I have patients who were able to get who had some connections to get it done from Toronto. And finally, we were able to get it done in Thunder Bay. Now, the new rule that I was talking about initially that the Cancer Care Ontario has mentioned is that they are allowing now MRIs to be done in a patient who is biopsy naive. So actually, if you have a high PSA before going for a biopsy, you might get an MRI. The bad part is Cancer Care Ontario can put such a statement, but then this means our MRI is going to be overloaded, which means huge delays, which means, is it better waiting for an MRI to get a biopsy versus waiting for a lot of, like, maybe 4, 5, 6 months, as we know the MRI can get delayed like that, versus getting a biopsy right away? That's a very tough situation that the Cancer Care Ontario has put us in. And I definitely would have loved if our system could afford to give everyone MRIs for the prostate, because even if it's me, I would not have a biopsy myself before an MRI. But the reality, and this is where I like the economy of our healthcare, we cannot afford that. Our healthcare cannot afford that because we do not have this luxury. In the States, they do that. My brother does that, but we don't have this capacity. So for some patients, we might do it for sure. Those patients where we find it will be a huge difference, but for most of the patients, it would not be offered, or it can be offered, or it can be an option, but then the patient has to realize that I cannot put him as a priority over a patient who needs it for surgery planning and stuff like that. So this is where it becomes a very tricky situation. And we're gonna face it a lot more in the future as this becomes more and more like not only general knowledge, but more and more of a common practice. But we are the only people north of Toronto anyway who do MRI prostates and MRI fusion biopsies. So imagine if I start getting patients from Sault Ste. Marie and all these kind of areas, it will be a huge load on our system. So well, I hope this was informative, and I'm open for any questions. I would stop my sharing.
Dr. Shahrour, could you clarify what percentage of biopsies now are being done by the peritoneal versus the rectal ones?
0, because I am the only one who does the fusion, and I'm the only one probably going to learn to do transperineal until I can come back and I can teach it to my colleagues. And I have been bombarded that I could not find any time to go down and sit with the guys in North York. So this is actually something that we're planning and hoping for to be done before December, but we have been trying, but it is not an easy situation because of the workload. It is not something that is easy, but I'm hoping before the new year I would have learned this technique and I will start teaching it to my colleagues, and all our patients should get the transperineal. Now the transperineal is time consuming, but again, we are this is definitely like once we go transperineal, I'm not going to allow any transrectal to happen because there's a huge difference. Like one patient gets an infection from a TRUS biopsy, and I'm sure someone probably had it. It sucks. It's horrible. I've had my patients in the intensive care. Thank God I never lost anyone, but I always tell those patients, I always tell some of my patients about the story of, not me, of one of my colleagues in Montreal. We had a young guy who is very young, and he went into a vegetative state from brain infection. This is one complication too many that should never happen. But again, government, this is gold standard. You go to any other center, gold standard is transrectal. But we are aiming to get better, and we should always aim better. We should not settle for mediocre. And our patients deserve more.
So if we're still doing basically transrectal biopsies, is the infection rate, does it continue to be around 30%? And are there any recommendations you have that might help people avoid the infections?
So the infection, we have had it 30%. This was from a self-audit done before I came in 2013, 2014, I think. Quite high. I remember in July, I received a phone call from one of the world leaders and Canadian leaders in prostate cancer from BC. I have to say it was a very odd conversation, because one of my patients, I diagnosed them with prostate cancer, and I wanted to give it, like I told him, you need a biopsy. And he wasn't, he asked me about the infection rate. I told him the last infection rate that is reported is around that. Yes, we have it less. Definitely, I don't have 1 out of 4 or 1 out of 3 getting an infection and going to the hospital, but definitely it is, I would say, at least 10 to 15%, if not more. And this doctor calls me from BC. He's like, oh, this is very high. This is unheard of. I'm like, well, no, that's in the literature. And he has infections of his own, because I know people who went to him, and which is, it happens. Now, now he does not even have a fusion capacity. He does what we call cognitive fusion. But again, what we are trying to do, we should be aiming for the transperineal. Now, for our patients, what to do, I think in general, taking lots of antibiotics is something that can be a problem, because antibiotics would make you have resistance, and the resistance would definitely can affect that. Now, drinking a lot of water, making sure you're not going into retention, because if you're having bugs and you're able to pee them out, that's one thing. And if you're in retention, you cannot pee, that's another thing. The bugs would continue to grow. I think I do not want to put any role on the patient for the prevention of the